Hello and namaste to all of you. This is Name-Shalu Singh from Jayoti Vidyapeeth Women's University. Today I'll be talking with you about the collection urinary albumin. And in further sections, I've also introduced about the urinary albumin and its work done upon the urinary quantitative measurement of urinary albumin at the international level and national level, and the how specimen is handled for the urinary albumin. So albumin is basically stable in untreated urine for at least 1 week, and when stored either at 40 to 20 degrees, and so it is if albumin is stable and in untreated urine for at least 1 week, and when stored at either 4 to 20 degrees, and freezing at 20 degrees causes fragmentation, and a single freeze thaw cycle may cause apparent albumin loss of 40%, though effect varies with storage duration and between individual samples. So the sample should ideally be analyzed fresh, and if prolonged storage is required, freezing at -80 degrees appears to preserve albumin integrity. And when measured immunoassay, creatinine is also stable in urine for a week at least, and at either 4 to or 20 degrees Celsius, and is unaffected by freezing at either -20 or -80 degrees. So prior to analysis, urine should be inspected for clarity and centrifuge if visibly cloudy. So what is the recommended collection time? So traditionally, an albumin excretion rate, or AER, is measured on a 24-hour urine collection, and most data monitoring response to therapy has been obtained on such collections. So this led to the perception of many clinicians that these collections represent gold standard despite being inconvenient to the patient and notoriously unreliably collected. So the timed, usually overnight collections were introduced to reduce patient burden. However, there is no evidence that timed collections provide more clinically valid information than a urine albumin creatinine ratio, and hence major international guidelines, including those of American Diabetes Association, caring for Australians with renal impairment, and International Diabetes Federation, and National Institute of Clinical Excellence, and National Kidney Foundations now recommend measuring albumin creatinine ratio on a spot sample. So the surveys conducted in 2006 and 2009 show that the majority of samples presented to Australian laboratories for urine albumin measurement are random spot collections, regardless of laboratory's collection recommendation. Now, the collection container that to be used. So there is some evidence that albumin binds to the surface of some plastics, so which may lead to under recovery of albumin at low concentration, and studies are being conducted. So at the Center of Disease Control, Health and Auspicious working party to quantify this effect. So in the meantime, it seems prudent to collect adequate volume of minimize potential losses. So biological variations for the albumin can be, so available data report with an individual variation in all urine albumin collection types with common estimates of 28 to 47%, and most studies confirm that a lower individual variation for ACR with as compared to AER. So first void of ACR and or overnight AER compared with daytime collection. So in a healthy individual, posture or exercise effects can cause a potentially misleading elevation of ACR and AER. So, and many expert groups, including NKTEP and IFCC and POWG, recommend a first monitoring spot collection for screening purposes. So now the confirmatory testing. So Most guidelines recommend confirmatory or repeat testing, although repeat intervals and repeat samples types vary. So PAWG draft recommendations are that initial positive ACR results should be confirmed by repeat measurements on 1 to 2 occasions within 3 months. So the key recommendations regarding uh, there there are several key recommendations regarding pre-analytical and analytical aspects of your urine albumin. And now, how total protein is measured in urine. So that says the measurement of total protein in urine has a number of limitations as a screening tool for proteinuria, and different methods may react disproportionately for each protein present in a given urine sample, making standardization impossible. And there is no universally accepted definition of proteinuria, with normal varying from less than 150 or to uh, more than 300 mg per dl. So more than 150 to more than 300 mg per dl, and 23 to 100 mg millimoles creatinine. So as well, urine protein measurement is less and robust at low levels of protein than in urine albumin measurement, and it is insufficient sensitive to detect all clinically important concentrations of urine albumin. And some authors have questioned the commonly held view that screening using urine albumin alone would miss tubular proteinuria, and methods of measuring urine total protein in Australasia are broadly divided into turbidimetry and using benzothionium fluoride, and dye binding using pyrrolol red, and only 18 to 265 laboratories using other methods. So end of the cycle report for the cycle 52 on the basic urine program from RCP-AQAP covering the period July to November 2010 shows that for a medium value 0.12 grams per liter, or participants reported values between 0.04 and 0.25 grams per liter, while intercohort trial range was significantly tighter and only one laboratory failed the allowed limit, and performance was less uniform at the higher median value range, that is 2.07 grams per liter, and hence the 15 laboratories failed the allowable limit criteria, and how a majority performed well. So it concludes that screening of proteinuria and chronic kidney disease should be done by the measurement of urine albumin on a fresh first morning void, and the reference measurement system is being developed that will validate the current use of common decision limits and facilitate harmony of results between laboratories, and this will particularly importantly at low levels of urine albumin. In the meantime, laboratories can improve patient outcome by standardizing sample collection and handling. So PAWG has made recommendations to facilitate this in Australasian laboratories. So this was all about the collection of your albumin. Now, further about your quantitative estimation of albumin, I'll be discussing with you in your next lecture. And until then, take care and goodbye.